or it used to be. It used to be rare up to about 20 years ago. And now it's popping up. But if you take the people that live there where diverticulitis is rare, and then they move to Western Europe, and then you see that their children, as well as themselves, they develop diverticulosis. So we know that it's not something that's genetic. We know that it has to do with how you live and what you eat. So basically, the consensus is it has to do with what you eat, and that we should all eat a lot of roughage and drink fluids and take some walks and things like that. So I would stick to a high fiber diet if I had diverticulosis. That may keep the diverticulosis from becoming diverticulitis, right? You have diverticulosis, more than half people over age 50 have diverticulosis. So it's not a big deal to have, really, but you don't want it to be inflamed so you get pain, right? So high fiber diet, I would drink a lot of fluids, get some exercise, and I would talk with my primary care doctor so that they're aware of your symptoms and they can advise you. I will get a colonoscopy too, because you have to make sure it really is diverticular disease and nothing else that is causing your symptoms. So, was that okay answer?
I already did the answer.
Yeah. So if you have diverticulosis and you have pain and fever, usually in the left lower quadrant, maybe some diarrhea too, and you start feeling that a little bit, and you go, what are they going to do? What are you going to do about it? Well, the first thing is when you feel those symptoms is that the colon needs to rest. So if you show up in the hospital, we will put you in the hospital, we'll put you on bowel rest, perhaps, if you're sick enough from it, and then we'll give you antibiotics. And then after a while, you'll feel better, and we put you on a soft diet, maybe liquids first, and then maybe some soups for a few days. So that's what you should do. That's how you should think about it. But in the long run, when you don't have symptoms, so when you're just walking around with your diverticulosis that is not inflamed, that's when you need to have roughage, fiber, drink fluids, get some exercise so that the stool moves through the colon easily. And that's what it's all about. And you see that 85% will get better with this kind of management. So most people don't need me, right? They don't need to have surgery for this. Even if you get an abscess, a lot of times, bacteria, if you have a perforation, bacteria comes out, you get an abscess, pus next to the bowel. Even then, a drain can be placed, you get antibiotics, and you may still not need surgery, at least not always. I thought this was funny, actually. So it's just to remember that not all diverticula are angry. Some of them are happy, and most people have them, right? So stay on the fiber and keep them happy, and then maybe you don't have to worry about it that much. Now, if 85% of people that come in do well and get better on medical therapy, what about the other 15% where it didn't work? They get fever, pain, sepsis, and symptoms get worse. So now we're getting into who should have surgery. Should all those people have surgery? Well, we have to do it case by case, person to person. It depends on who the person is, what the risks of surgery would be, and how important it is for the patient and what kind of risks the patient would want to take, risks with surgery or risks with not having surgery. So it's a long discussion. You can also get complications from diverticulitis, such as abscesses or maybe an abscess that tries to drain itself. So it will drain itself to the urine bladder, or to the vagina, or out, so then bacteria will go that path all the time, and that may be an indication for surgery too. So I guess I talked about the first two already. When it's complicated, then we can discuss surgery, and then we need to figure out what kind of surgery we should have too, because there are many different types of operations that can be done for this. So uncomplicated diverticular disease or diverticulitis. So if complicated disease needs surgery, what is uncomplicated? Basically, when you don't have a perforation that you can see on a CT scan, you may have pain, but you do the CT scan or the X-ray, or you come to the hospital and you're not that sick. So you see that there's no perforation, there's no abscess, at least there's no abscess that's far away from where the colon is. It may be a small one right next to the colon, that's okay often. Stenosis, that means an area that is narrow, so that it's hard for the stool to get past, basically. And if you have that, all the stool would dam up north or upstream from that stenosis, and that's a problem. And if it becomes tight enough, that stenosis, then nothing can go through. So then we call that a bowel obstruction. That would be a complication, but you don't have that, then you don't necessarily need surgery. It says no fistula. So we talked about fistula already. If you don't have that, you may not need surgery. You can bleed from diverticula also. I'm going to show you some picture, a couple of them of that, so you can see what that looks like. But if it is uncomplicated, like I said, antibiotics, and then once things have calmed down after about a month or 6 weeks maybe, then you do a colonoscopy to make sure that there's nothing else. Because there are other things like colon cancer that can give similar symptoms sometimes. So we can't just say that diverticulitis is just diverticulitis and then not check. So that's why we do that colonoscopy once things have calmed down. If you just had a colonoscopy 6 months earlier, then you may not need that. So complicated diverticulitis, that would mean an abscess, especially if it's far away. Purulent or feculent peritonitis, that means that in the abdominal cavity, the abdomen is almost like a bag. Think of it as a bag, and in that bag you have all your intestines swimming around, right? And peritonitis means that there's bacteria inside that bag, and that is very painful. Sometimes even stool can go into that bag, and that then you get very sick and you will absolutely need an operation. We talked about fistula. We know what that is now, right? The connection between the colon and another organ. Stenosis was that it was tight somewhere so that stool couldn't flow through. And then we have bleeding. This is a little bit too maybe doctorish, but it's just to say that there are things, other diseases that people can have that makes it more likely to have problems if you have diverticular disease, and things like diabetes, if you have some inflammatory disease or your joints or your tissues or your blood vessels. If you are taking a lot of opioids or other pain medications, and weight is also something that makes things a little more difficult. I had to have this here because if I talk about diverticulitis, then we have this staging system. Basically, diverticulitis, stage 1, stage 2, stage 3, and stage 4. And there was this doctor, his name was Hinchy. They came up with this, and basically most people that come into the hospital with diverticulitis, they have stage 1. That is, have pain, maybe some fever, maybe your lab tests show that there's some infection going on, and they do a CT scan and they see that the colon is thickened. And it could even be a small abscess right next to the colon. That would be stage 1. Stage 2, then you have an abscess far away from the colon, maybe in the pelvis or somewhere else in the abdomen. And stage 3, that's when you have that pain with bacteria inside the bag, inside the abdomen where all the intestines are. And stage 4 is actually a hole in the colon so that stool will come up there, and that's not good. Not good. And yeah, no questions.
Is there pain associated with that? All of these different.
Yeah, the bad things are associated with a lot of pain. You would know it, and everybody around you would know it. Yes, pain and fever, and you'll be really sick and weak.
So it's sort of a warning. There is a warning for pain.
The pain comes, and then when it's just pain and maybe a little fever, but the pain is just in one area, then that will be usually uncomplicated, and people come to the ER, and then they get checked out. If you have one of these more severe, if you have peritonitis, you will have a lot of pain, and you would have pain when you walk, cough, laugh, you push on your belly, and you'll be really sick. So you wouldn't miss that. You don't have to worry about having peritonitis, because if you do, you don't have it. Yeah. This is the same, what I just said is different stages. And these I just have here again. I'm not going to go over these in detail, but basically when you come into the emergency room, I don't know how many of you guys have had diverticulitis, at least one person. So if you go to the hospital nowadays, usually, or whatever you go to the hospital for, you get a CT scan nowadays, but you'll get a CT scan of the abdomen. And we do that because then you can see if there are abscesses or where they are and how inflamed or infected it looks. These are all okay, you can see here. I know you can't, but right here, there's some inflammation. This is somebody who had a perforation and actually had what we call Hinchy stage 4. So this patient there's a hole here. And there's a bunch of pus around the hole, and stool had come out of that hole in the colon, and the patient got very sick. And, when that happens, that's something people die from. So then you have to go to the operating room and see where that hole is, and usually you would have to remove that part of the colon. And a lot of times, not always, but usually people would have to have at least a temporary colostomy bag after that when it becomes an emergency like that. So I have these just so I would remember to talk about fistulas. This picture, this is the urine bladder. The main thing is that there's a little air in the bladder. That means that air must come from somewhere. It shouldn't be in the bladder, and then usually it comes from the colon. And that means it's a connection between the two. This is another picture from a CT scan, and it shows it's a small intestine here, and it's way too big, way too wide. So that means that whatever is in there can't get through, and it damps up and it becomes big, and we can see it on the scan like that. And that can happen because the small intestine, small bowel, gets stuck on the inflammation of the colon, and it becomes a kink, and then what's in there can't move through, for example. Ouch, exactly. This is a CT scan of just one picture, but it's a large colon, and so there it is, one of those stenoses, you know, that the stool couldn't go through, and then the colon dams up, becomes big like that, and then we have to do something about that. So basically, when we say conservative, we mean not operate. And so that would mean if you just have acute diverticulitis, like we've said, and you come to the hospital, usually rest the bowel, you get some IV fluids since you're not drinking anything, and then you get antibiotics, and then it gets better. If you have the same situation, but we see an abscess on the scan, then sometimes it's better to operate, and sometimes it's better to put a drain there or just treat with antibiotics. This is a picture of when it's the interventional radiologists. We have a lot of good ones actually at University of Florida. I've only been here a few months, but they have already helped with a lot of things. So basically, here it's an abscess, and this is the drain as it goes in there, and then, you know, it's just a tube that goes into where the abscess is, and then the pus that's there gets a chance to come out. And when it comes out, the antibiotics will work better and patients get better, hopefully. If you don't do that and the abscess gets bigger and bigger, it will try to drain itself, but we don't know where it will drain to. Maybe it will drain to your urine bladder or somewhere else. So this is a way to control where it drains to. So that's kind of the idea. Yeah.
This situation, were they suspecting this, and so the interventional radiologists knew to be prepared to do this?
Yeah, so if I have a patient that comes into the hospital and they have pain, and I think this might be diverticulitis, and maybe the ER doctor have ordered a CT scan I can look at, or maybe we did, and then we see that abscess on the CT scan, then I have to think, well, what's best for this patient? Should we go in, make a cut, and drain that pus out, or is there a smarter way? So I call sometimes the interventional radiologist, and then they'll say, yeah, we're happy to do that now in the middle of the night. Or usually it doesn't have to be in the, you know, it can be, it's not, it has to be done right away, but usually they do it within a few hours usually.
I was just curious because I thought maybe they were having a CT scan to see what was going on, and they went ahead and did this. But it sounds like it's progressed further along.
Yeah, right. It will be usually, they always do a CT scan that helps them to see where to put the drain, but right, so you end up with 2 CT scans, true. True. Sometimes they can use ultrasound too. Yeah, that's true. If you've had diverticulitis for a long time, then you get chronic complications. And we talked about fistulas. So they usually, the most common is to the bladder, vagina, or uterus. But they can really go anywhere, these fistulas. And the problem with having a fistula to the bladder, for example, is the bacteria from the colon gets into the urine, and then you get urinary tract infections all the time, and that's not a good thing. So, for example, hematuria, that means air goes out in the urine, because air from the colon, so people will notice that when they pee, that air comes out. And then fecaluria means that it's actually poop, stool comes out in the urine, so it looks, it's debris in it or the wrong color or something like that. Vaginal discharge, of course, if there's a fistula to the vagina, people will notice that. So most of the time, fistulas, you have to fix them with surgery, but there are, I think we just had one case where it actually healed with antibiotics and things like that. Sometimes you can have it drain for a while and it actually heals up. Strictures, it's the same thing. We have to make sure it's not cancer, right? So we have to look for at the stricture with a colonoscope to make sure that we know what we have. Okay, this is the bleeding. This is the one I think this is the only complication of diverticular disease that doesn't cause pain. So this is the diverticulum here, and they all have blood vessels that run in the corner of them. So that can start to bleed, and that's what's called a diverticular bleed. So it can be a lot or a little, and it can be not a big deal or a very big deal sometimes. And the problem is to know where this blood comes from. That's our problem, to try to find where in the colon the bleeding comes from, and so we know where to do something. And if worst case scenario, if we can't figure it out, but we know it's from the colon, sometimes we have to even take the whole colon out if it's bleeding a lot. But that's rare. I mean, very rare. I think like once every 7-8 years for me, right? So here is a colonoscopy picture. There's a bunch of blood here coming out of this diverticulum there. That's a hard picture to get. It's that usually when you try to find it with a colonoscope, you just see blood and you can't see where it comes from. But that will be one way to figure out where it comes from. You can also do angiography. You know, again, the interventional radiologist will help us, and there are other kinds of scans where we can look for this. Limited colectomy, that means you just take part of the colon out. That's what we would want to do. I would want to know that it's from the sigmoid colon, for example, and then I can just remove the sigmoid colon and the patient can have the rest of the colon left. But sometimes you have to take all of it out. So surgery should not be done unless it's helpful, right? And you don't want to cause trouble by doing surgery. So that's those are the first rules. And then most people don't want to have a bag, so we try to avoid that, but sometimes, you know, it's not possible, and it becomes a discussion about risk. But most of the time nowadays, people do not need to have a colostomy or an ileostomy. So this, I thought maybe could be interesting for people. It's just an old picture out of the textbook, different operations that can be done for diverticular disease. This, you know, the colon is like a horseshoe, right? So the one that goes across, that part of it there is transverse colon. You can just pull it out. As a colostomy, that means the stool wouldn't go past below that. And then the colon would have a chance to heal. That's old school. That's very rare to do for diverticulitis today. But back in the day, that was the most common thing to do. This one happens occasionally now. It's actually the same operation. You just bring out the left side of the colon as a colostomy like that, but you don't remove any intestine. The most common for an emergency operation is this one. It's called Hartmann's operation. Basically, it is removing the sigmoid colon because that's where diverticulitis most often happens. So you remove that part, and then you make a stomach colostomy, right? Then you have avoided the risk of making a connection. Because if you make a connection, it can break open and you have a situation even worse than what you had, you know? So you got to think about that. Here are the two, I would say, most modern ways. That is that you remove the part of the colon where the problem is, and you sew the two ends together, so you make a connection. But then upstream from that connection, you make a colostomy so that this connection gets a chance to heal for a while. Until then, when you see that it has healed, you can easily put that down, and then it will work the way it did before. So this is actually a robotic little video. I don't know, you have to tell me if you if you think it's not nice to watch these kinds of things, but this is from, this is probably about 10 years ago when we just started with the robotic surgery. But you see, the advantage is that you don't have to make a big cut to get there. Instead, you have these arms, and right now, this is the sigmoid colon up here, and we're just sort of freeing it from where it is stuck. Down here is the rectum. And like I said, this is an old, I think this is from 2012, if I remember. It's 10 years old. Yeah, 2012, I think it is. So that's the sigmoid colon here. This is all the blood vessels and everything that goes to it. This is a little stapler that you can divide the colon with. I'll stop if you think it's too nasty. They're separated. So, and there's been a connection made, and we checked it, and then we put water or saline there, and then you insufflate the rectum with air. It's like if anyone has ever fixed a bicycle flat, basically you put it underwater to see if it bubbles. If you have a leak, you do the same thing after we have made a connection like that. So, I don't know.
We're doing great on time.
Are we doing great on time?
Yes, sir.
Okay, I'm just talking here. So
Maybe another 5-8 minutes.
no, I'm done actually.
Perfect.
Yeah,
I
yeah,
have questions then.
yeah. So
Stay in shape.
exactly. That is the rule of life, number one, right?
Yes.
And most people with diverticular disease will never need surgery. Remember, 85%, even the ones with diverticulitis, 85% just took conservative treatment and didn't need surgery, right? The people with diverticulosis, that means almost none of them will need surgery, right? Because it's so common. So when somebody tells you you have diverticular disease, it's really not a big deal, but you should be aware and try to behave in a way that you don't get the problems from it. If you have a good GP that can help you, that I think is helpful, and make sure you get your colonoscopies.
Are there certain foods not to eat if you have it and they tell you?
So if you don't mind repeating the questions, because.
Oh, yeah, the question from the auditorium here is there some type of food that we should not eat? And I would say no. I would say you can eat anything, but I believe in moderation with everything, right? And I would like to phrase it, you should eat a lot of fiber. But that doesn't mean that you can't have mashed potatoes, right? I wouldn't eat only mashed potatoes, right? So make sure you eat a lot of fiber and drink a lot of fluids, and find a way to walk around the block once a day, I think, if you can. Yeah.
Can I,
Yes.
let me do just one thing real quick. For a second.
Yeah, if you have questions at home, if you can type them in the Q&A chat, that'll allow us to answer them. If you raise your hand, I have no way of acknowledging you. So just type a question in the chat and then I'll ask him out loud and he'll answer them so you guys can hear it. And we'll do the same here. So we'll do a little bit of questions from the folks online and some questions from the folks in the room. You can definitely start with the folks in the room.
Yeah.
Thank you.
Yes, ma'am.
I think at one time they were telling people not to eat like things with seeds and that.
Yes.
Yes.
Same thing my mother.
That's a little bit of a, yeah, I know people say that. I just personally have never seen any real data that anybody has shown that it would be dangerous to eat seeds. And I have never seen a person that I have operated on where seeds have been stuck in the pockets, you know? So I think that theoretically, yes, I guess a seed could get into one of those divots and get stuck, but it doesn't seem to happen. So I just figured I'm not going to deprive people of seeds, but that is, that's a question out there. Yeah.
Popcorn is what someone told me.
Yeah, popcorn. I think, again, it's Saturday night, you go to the movies, you get a bag of popcorn, you eat the whole bag. That's probably not good for a lot of reasons, but I think it's okay to have some popcorn. But I wouldn't say just because you have diverticulosis doesn't mean you can't have popcorn.
We have a question over here.
Yes.
Is diverticulosis reversible, or do you just learn to live with it once you have it?
So diverticulosis, which is having the pockets without any inflammation, which is what half the population over age 50 has. That is not reversible. That once it's there, it's there. So then if you have that, but you take your fiber, drink your fluids, do your exercise, you're minimizing the risk that you will get diverticulitis, right? So that's not reversible.
I have a few questions from home.
Yeah.
Somebody wanted to know, are probiotics helpful to take? Is it helpful to take probiotics for your gut health to help avoid some of these complications?
Okay, yeah, I think probiotics, the question is, probiotics helpful? I can't tell you whether probiotics are helpful for avoiding getting diverticulitis, but I can say that probiotics is helpful. It's a way to have a normal gut flora, as we say, have a normal types of bacteria that should be in the intestines. And there are a lot of intestinal problems that happen if you don't have a normal flora of bacteria. So I think it will be very healthy to take probiotics.
Right.
By the way, if you eat fresh blueberries, and not frozen, but fresh blueberries and fresh blackberries, they have a lot of probiotics on their shell, and also some of these kefirs and those sort of things. Yes, ma'am.
Kimchi food, the kimchi.
Oh, the kimchi.
There's a lot of suggestions.
That's a good suggestion. If you like it,
Yeah.
yeah, then that will work too. Yes.
What is the relationship between diabetes and development of diverticulosis, diverticulitis?
So I would say that it probably has no relationship with getting diverticulosis. It might be, but if you get an infection, so you have more sugar in your system, and then you have a little micro perforations, so some bacteria gets out there just a little bit, and there's a lot of sugar there. Then the bacteria, they're going to grow, and they're going to like it because they feed off of that. So I guess an appropriate way to put it would have been not controlled diabetes is a problem. That's probably how it is. Mm-hmm.
I have a question from home. Someone wants to know, how long does it take to completely heal from a diverticulitis flare-up without an acute complication?
Okay, so how long does it take to heal from acute diverticulitis uncomplicated acute diverticulitis. So usually, it depends on what you mean by healing, but you know, when people come in the hospital, if it's not too bad, they're usually pain-free after 3, 4, 5 days. But of course, if I did a CT scan after 5 days, when they were pain-free, there may still be some thickening of the bowel that I could see. But usually they're pain-free after a number of days, and then we have the soft diet for maybe a couple of more weeks, and then go on the fiber. Sometimes people have what's called, I don't know what to call it, lingering diverticulitis. You know, maybe you have it, you got a little bit better when you were in the hospital, or they treated you with antibiotics, and you're better, you're walking around, but you're just not quite, it's not perfect, right? And there's still some pain. That can take much longer. And if it takes a long time, then I think that would be one indication for surgery. I think at least it's an indication to come and talk and wonder what, you know, can surgery help me in this situation? It's important to know, though, diverticular pain is an interesting phenomenon, right? So sometimes, you know, you can only, if you put your hand on a hot plate, you feel the pain even before your hand have been put down. So there's a lot of things going on with pain. But if you have diverticulitis and it got better, but it's not good, then that may be a reason to come and talk about what else can be done for you.
Also at home, I had a few questions about the best ways to get all of that recommended fiber. They're saying they're over 55 and 18 milligrams of fiber seems really hard to come by. Should they add Metamucil to their diet, or what would you recommend?
Yeah, I mean, I don't think I can say in the brand names unless they pay me. They don't pay me.
Right,
so
right.
I guess I can say
Fiber additive, XYZ.
But so I personally, I just buy the fiber at the pharmacy that has a red tag on it, to be honest. And I do think that's a good way. I do think that we should eat all the vegetables, the spinach, the broccoli, the cauliflower, the carrots, all those things will help a lot. But it's easy to take 1 tablespoon of the powder fiber and mix it in a glass of water and do that once a day, for example. So I think that's a great way of doing it. Yeah.
Any other questions in this room, or do you want me to keep asking the questions from home? All right, there's some good ones. Someone wanted to know if Crohn's disease is at all related to diverticular disease. Is it a precursor, or are they related at all?
So the question is if there's a relationship between Crohn's disease and diverticulitis. No, I don't think there is a relationship between the two, but nobody knows why people have Crohn's disease. So maybe there is one, but it's actually quite unusual to have somebody with diverticulitis and also Crohn's disease. It is actually also unusual to have somebody who has diverticulitis and who also has ulcerative colitis. So there's no relationship between those, and they're not precursors.
Somebody else wanted to know, how would you diagnose a fistula?
Okay, so the question is, how would I diagnose a fistula? So it depends on where the fistula goes to. So if you have a fistula, most commonly they will go to the bladder. They will go between the colon and the bladder. So what you would notice, it could be that you had urinary tract infections a lot. Of course, a lot of people have urinary tract infections, and it's not because of fistula, it's a common thing to have. But if you have a fistula, you certainly would have urinary tract infections. You would also notice that you had air. When you urinate, it will be air coming with the urine stream, and people notice that. It's a lot of bubbles and sounds when air go through. You would also notice that there's some debris that will come in the urine, and they would have, it could even be brown colored or a different type of color. So that's what you would notice. And then you would go to the doctor's office and they would probably do a CT scan and they would see that there was air bubble in the bladder. And they might send you then to a urologist that will look with a cystoscope into the bladder and say it looks like a fistula, for example. And then you will need a colonoscopy and et cetera. But yeah.
One more. One person said if you've had uncomplicated diverticulitis more than 3 times, is surgery necessary? That's what their gastroenterologist told them. Well, we've seen here 3 times, you have to have surgery.
Yes, 3 strikes you're out. So yeah, that's a recommendation that you see in a lot of books. And I think it makes sense in a way, but this is not cancer. And we never know. You may have had diverticulitis 3 times, but it may never happen again. We don't know. But we do know if it keeps repeating itself, it gets more and more likely that it will repeat itself. So this is the kind of discussion that I would have with a patient if they have had repeated episodes of diverticulitis. And I think that I would say that the rule is, yeah, why you go and see a colorectal surgeon if you've had 3 bouts of diverticulitis. And then there's no rule that says you have to have surgery, but I think it's probably time to discuss and talk about if the advantages and disadvantages with surgery, and then you decide based on that.
Right. I think I've got one last from those at home, and then if anybody else has one, we'll get to you. Yes, sir. A couple of questions about the relationship between constipation and diverticulitis.
Okay.
So do you feel that the 2 are related?
Yeah.
Thank you.
If there is a, and that I probably should have added in the slides. So that was good that question came up. So yeah, the question is there a relationship between constipation and diverticular disease? So I think we can say it is. And when it's healthy for the colon, if the stool moves through, not necessarily rapidly, but it shouldn't go slowly. So if it doesn't move through rapidly, then it takes a lot of peristalsis, a lot of force for the colon to move it through, and you get high pressure inside your colon. And then with that high pressure, you're more likely to get those outpouchings. That is what diverticulosis would be. So that's the theory behind that relationship. But it is true that people who have complaints of constipation are overrepresented with diverticulitis. So yeah, I agree with that.
Actually, I have a 2-pronged question. One of them is on colonics. I
Colonics.
mean, as far as prevention goes, I mean, the reason why you get those pockets, I mean, to my understanding, is that people eat, well, they eat an over-processed diet. There's not enough of it. It's not sweeping the waste through the colon in a healthy way, where there's buildup. And colonics, might be an option for prevention as far as, getting rid of that waste that sticks to the colon for whatever reason.
So the question is, do I think that colonics will help? Yeah, well, so colonics is basically a bowel prep, you could say. It's basically, you have a lot of stool in your colon. You, instead of drinking the bowel prep to clean out your colon before a colonoscopy, you take kind of a enema. It's like an enema machine that sort of washes out the colon, and then the colon is clean after that. So I think it's like taking a bowel prep. I don't know if taking bowel preps or colonics will prevent, people from getting diverticulosis, because I don't think that has ever been shown. So I can't really say that I believe that it helps. If you're constipated and you do colonics, or if you're constipated and you do bowel prep, that will certainly clean out that constipation. And I think people feel relief for a number of days anyway after any of those treatments. And I think that can be a positive thing, but I wouldn't go out on a limb and say that they would prevent diverticulosis. I'm not going to say that they won't either.
That's what I'm saying.
Yeah, right.
See, I've never had one.
Yeah,
I've
that's
never
right.
had any problems.
Yeah,
So it's not from my exact, life experience that I'm talking about. I'm just talking about what people have told me, especially people doing colonics.
Yeah.
They said that I guess some people will go in and actually massage the intestine as they're getting the colonic to find impact